Okay, good morning, everyone. It's 8 o'clock. Welcome to our 10th week of Cardio Echo, reducing the burden of hypertension. If you will please keep yourself on mute unless you'd like to speak. We also have a chat feature that you could message and ask your questions that way. Please put your name and your location there to record your attendance. If you somehow happen to be disconnected at any time, Rick's phone number is on the screen. If you're also joining via phone, you can mute and unmute yourself using *6. We will introduce the hub team members, even though we're all joining from remote locations this morning. I'm Shannon Switkowski, the clinic coordinator. Rick?
I'm Rick Carnaccion, the web content producer.
I have Dr. Rao.
Good morning, I'm Goutham Rao, I'm the director of ECHO.
Dr. Werner?
Jim Werner, Case Western Reserve University behaviorist.
I have Dr. Wright. He's on mute. You are muted.
All right, can you hear me now?
Yes.
Okay, Jackson Wright, Emeritus Professor of Medicine, Case Western, and co-lead of the Team BP for Cardio.
Okay, Dr. Rao, you could go ahead.
Okay, thanks for joining us. I know it's a challenging time for many of us on many fronts. We have, believe it or not, at UH emergency preparedness meetings every 3 to 4 hours to prepare for what's to come. So give you an idea of the scope of things. And I know everyone's schedule is highly distorted. So with that introduction, I'm very appreciative of Dr. Lamb to give his presentation this morning, as well as I believe Marilee Clemens has a very interesting case for us to present as well in one of our special populations, the elderly. So Dr. Lamb, it's all yours.
Okay, let me advance here. So the topic, special populations and hypertension, older patients and patients with disability. The team helped me slash and burn many of my slides yesterday, Shannon and Rick and Dr. Wright. So I had to leave out most of the slides for the disabilities. They are in the bigger slide set. So we won't spend too much time on that, and did cut out a lot out on the older patients, but we'll hit some highlights here and then spend some time on discussion. So there's the objectives. Most, again, will be centered on the first bullet point. So we'll start with why this focus on hypertension, people 65 and older. Fairly obvious. Projected growth in the population is pretty significant, especially the 80 and older population. There's a high cardiovascular disease risk and burden in this group, and as we'll see, a very high prevalence of hypertension. Pretty much everyone in this age group crosses into the danger zone in terms of hypertension. So worthy to talk about how to manage them. I like this little thing we use on teaching rounds sometimes. If you've seen one 80-year-old, you've seen one 80-year-old. So it's a very heterogeneous group as people age, much more than a younger group. Chronologic age does not always equal biologic age. We've seen 80-year-olds who are fairly debilitated and dependent, requiring 24-hour care. And we've seen 80-year-olds who travel all over. So I think it's important to keep that concept in mind. And the other point is focusing on functional status really helps guide me a lot in taking care of these patients. So we have these fit, active, independent patients. We also have frail and dependent, and a lot in between. So try to keep that in mind when you're deciding on management. This again is a general guide in terms of deciding on treatment of various conditions. Notice difference between male and female, but also notice you get it to 90, 95-year-old, the life expectancy is still in the range where blood pressure management can be effective. So there's not as many patients in trials in this age group, but it's still, the expected time to benefit is actually shorter than their life expectancy. So sometimes it does actually make sense to treat patients in this age group. And as you can see, definitely in the groups that are in the 65 to 85 range. So let's look at a study that was published a little ways back. Men, as we noticed, live a little bit shorter than women, and someone decided to look at what maybe are some non-genetic determinants of a long life in elderly men. So it's part of the Physician's Health Study. The mean age was 72, and they were followed for 25 years to ascertain what could be the non-genetic determinants of a longer life, survival to 90. And interestingly, if you could focus on 5 factors in your 70s, you may have a pretty good chance of making it to your 90s. These were the obvious ones: smoking, diabetes, obesity, hypertension, and a sedentary lifestyle. If all factors were present, the probability of reaching your 90s, if you were in your 70s, was 4%. If none of them were present, the likelihood was over 50%. And then there were several in-between percentages based on how many of these factors you had. The other interesting thing is that longer lifespan was accompanied by a delayed occurrence of many diseases, often about a 3 to 5 year difference. Cancer and cardiovascular disease lagged 3 to 5 years later if you were in that longer lifespan group. And there was also an improvement in both physical and mental function in that group of patients. So a very important kind of thoughts about what we should prioritize when we see these patients, because especially if one of the goals is longevity, but not just longevity, but improved function and delayed onset of disease. And here's one of the figures from the table. You can see here's the group, no adverse factors, 54% survival. Notice hypertension, if the present, that would decrease it to 42%. If we looked at sedentary and hypertension, decreased it to 36%. By the way, regular exercise had a huge impact in terms of improving survival. And then if various mixtures of things, if all 5 factors were present, it was down to 4%. So pretty compelling kind of evidence that maybe targeting these factors could make a difference in people's lives. One of the issues with the patients, and maybe one reason there's some therapeutic inertia, are all the challenges that you deal with when you look at hypertension treatment in this population. So one we already mentioned was the high degree of heterogeneity. Comorbidity is also a major factor in this group. Polypharmacy, so we have more diseases, more medications, and sometimes the tolerability of these medications is less. Frailty, although we've know from the SPRINT trial that frail patients can benefit from treatment. Cognitive impairment, variable life expectancies we talked about. There has been a concern about a J-shaped curve. So as you lower the diastolic pressure, blood pressure homeostasis and organ perfusion may be affected, but SPRINT seemed to show that despite doing that, the survival and cardiovascular outcomes were actually improved. And then there's concerns about fall risk. In addition, all of these issues associated with hypertension seem to increase in the older population. So there's a higher rate of white coat hypertension. There's a higher rate of conversion of white coat to sustained hypertension. There's a higher rate of uncontrolled hypertension, of extreme nocturnal dipping, of resistant hypertension, of orthostatic hypotension, and postprandial. So very important to keep these in mind as you're treating patients in this older age group. Just a quick mention of the prevalence. We talked about most of the people in this age group cross into the danger zone. So if you use the previous guidelines, about 140/90, 60% in the 65 to 74, 70-some% in the 75 plus. Now that we have the newer guidelines with 130/80 being defined as hypertension, notice that 3/4 of the population, both men and women in age 65 to 74, are classified as hypertensive, and 80 to 85% of those in the 75 group. So this group, pretty much when you see them, are going to have hypertension on their problem list. The next slide, the SPRINT trial, we've talked a lot about. Just to mention, this is where drove a lot of the new recommendations from the more recent recommendations from ACC. Again, they were at least 50 years old. They had a higher risk, and they did include 75 or older as a higher risk group, intensive treatment, and then here's the difference in terms of blood pressures. Notice that they did require more drugs to achieve that systolic blood pressure. They have now looked at various subgroups in that SPRINT study, and here's one of the studies that pertains to the older population. It's called SPRINT 75 for short. Dr. Wright was involved with that, published in JAMA. It's exploratory analysis there of patients over 75 in the SPRINT trial. Mean age was 79.8. Notice the mean blood pressure, 74% white, 10% orthostatic hypotension. And importantly, again, fit, less fit, and frail patients were included. The results showed, as in the SPRINT group, a significant cardiovascular and mortality reduction benefit from intensive treatment. They were able to, the older patients were able to tolerate the intensive treatment without serious irreversible adverse events. There was no difference, surprisingly, in the rate of injurious falls, and there was not any difference in rate of withdrawal and loss to follow-up, despite very intensive treatment of blood pressure, bringing it down to the 120s. In addition, if I can, sorry about that. One of the most compelling pieces of data, I think, is the number needed to treat. With a higher absolute risk of cardiovascular disease, the older patients tend to benefit more from antihypertensive treatment than younger patients. So notice in the entire SPRINT cohort, to prevent one cardiovascular event, you had to treat 61 patients, much less in the SPRINT 75 cohort. To prevent one death, you had to treat 90 patients in the entire SPRINT cohort. In those patients who were 75 and older, you had to treat 41 patients. So again, a much greater benefit from treating the older population. There's also another, this just got published in March in Journal of American Geriatric Society, called SPRINT 80. So we have another subgroup that was looked at from SPRINT. And again, the benefits were significant. Now, if you look at the age breakdown, most of them were in the 80 to 85-year-old group. There were about 25% 85 to 90, and there were a few percent in the early 90s who were also included in this. Bottom line, 34% reduction in cardiovascular events, 33% reduction in mortality. And one of the interesting findings is 33% reduction in mild cognitive impairment. These are patients who have memory loss, but it's not severe enough to interfere with functioning. 10 to 20% of these can convert per year to patients having dementia. So if we can prevent this, it will have a potentially large impact in the incidence of dementia. There was a sub part of this that looked at patients who had lower MoCA scores. MoCA was a mental status exam that could be obtained online. Notice that there was less of a benefit with the lower MoCA scores in terms of cardiovascular disease and mortality. No difference in cardiovascular disease mortality with respect to gait speed. There was an increase in acute kidney injury. There was no change in injurious falls with the intensive group. But again, these were high-risk patients over 80, more susceptible to adverse effects, but still had benefit from treating hypertension down to lower levels. And so this was the paper here from just published this month. Again, conclusions: in those 80 and older, intensive blood pressure lowered the risk of major cardiovascular events, mild cognitive impairment, and death, with increased risk of changes to renal function. The benefits might not extend to those with the lower baseline cognitive function, but again, that was a subgroup analysis and may have to be looked at a little bit more. Another paper published this month, Dr. Wright was involved with this in hypertension and looked at orthostatic hypotension, which I mentioned was one of the challenges in this age group. And the bottom line was it was not associated with an increased risk of cardiovascular disease events, falls, or syncope. And being in the intensive target group did not alter that relationship. So orthostatic hypotension did lead to more hypotension-related hospitalizations, but that did not matter whether you were in the intensive or the standard group, and it didn't affect cardiovascular events or falls, and therefore should not be a reason to down titrate hypertension medications unless the patient's symptomatic. Then you have to use your clinical judgment and maybe make some adjustments. But overall, this was reassuring to know that even in the presence of orthostatic hypotension, lowering blood pressure to intensive levels made a difference. The other point we already made was that frailty patients both in the HIVET trial, which was an earlier trial of hypertension in the very elderly, and the SPRINT, who were frail but still living in the community, benefited from intense blood pressure lowering therapy. So it's one of the few interventions in this group that showed that benefit. One of the things to kind of keep in mind with all this discussion is it's not a one-size-fits-all, and it is looking at the whole patient. So really, even though you're just treating one condition, hypertension, you do have to assess their cognition, where they are in terms of functional decline, mobility, falls, frailty. We mentioned multimorbidity, polyparsin. So it's a little bit more challenging group, but yet they do benefit from treatment more. So it's worth this effort and important to kind of keep a baseline and follow along in these areas. So we just mentioned about Sprint Mind. So this again is another publication from Sprint. And again, didn't show the cat was already out of the bag if the patients had dementia and were treated. But if you could treat them before they developed MCI, you could reduce the occurrence by 20% in a statistically significant way. And with the conclusion from Sprint Mind that what's good for the heart is good for the brain. Again, I mentioned that the conversion rate is 10 to 20% per year from MCI to dementia. So if you can prevent MCI, you could impact significantly, possibly, the number of patients with dementia in this country just by blood pressure control. So that's that. So the last couple slides here on blood pressure are what's the target? We kind of focused more on the American College of Cardiology, American Heart Association guidelines from 2017. And a lot of this was driven by Sprint, but other trials also. And the bottom line, the A level of evidence and highest recommendation is to treat to a systolic blood pressure treatment goal less than 130, non-institutionalized. This is important because patients in nursing homes were excluded from many of the trials. Non-institutionalized ambulatory community dwelling adults over 65 who had an average systolic blood pressure. Your goal should try to be to get them below 130, keeping all those caveats we already mentioned. For those patients who have a high burden of comorbidity, many of them not included in trials, a limited life expectancy. This is where clinical judgment, assessing patient preference, team-based approaches to assessing benefit risk. It's not to say that these patients shouldn't be treated, but it takes a lot more nuance and again, clinical judgment to decide how low do I bring them, what drugs do I use, more intense monitoring for adverse effects, et cetera. The graph here really shows kind of an interesting evolution here and how aggressive we're being with treating hypertension. So this was an early trial called SHEP, systolic hypertension in the elderly. And notice with this one and the HIVET, hypertension in the very elderly, these patients were 80 and above. The treatment goal down here is higher than the entry goal for Sprint. So Sprint really lowered the bar here, and this is why you can see the guidelines changing from this recommendation of 140 over 90, JNC 7, 150 over 80, JNC 8, all the way down now to a systolic of less than 130 based on Sprint and some other trials. So the other point is choice of drug therapy. Again, I think you've discussed this a little bit, but it applies to the older patient. The preference is to start with the low to moderate dose thiazide diuretics, the long-acting ones like chlorthalidone being preferred, or a long-acting dihydropyridine such as amlodipine. And then as an add-on, maybe a ACE or ARB. They're all first-line choices, but in the older patient, we might try to start with these two and then consider the ACEs or ARBs later. Beta blockers not considered primary therapy because some trials showed they did not prevent stroke, and in trials with atenolol maybe even associated with a higher death rate. They again can be add-on later, but not as a primary therapy. So conclusion here, several decades, several trials, several randomized controlled trials, large numbers of older persons as we go along, including even a goal of a systolic blood pressure down to 120. More intensive treatment has safely reduced the risk for multiple age groups. I think has really changed the landscape here for treatment of hypertension. Just one slide on disabilities because of the time issue. And again, there's a lot to talk about here. A couple comments is the concept of health for people who are disabled and not disabled should be the same. So we shouldn't change that approach to these patients. Secondly, they do have higher risks, and often these are related to behaviors such as more smoking and more obesity, Sometimes there's mobility issues, et cetera. So they are at risk for hypertension. And a couple things that from a more practical standpoint is always assess the effect of medication in these patients in terms of their function who have disabilities. You'll run into patients with intellectual disabilities and other types of disabilities not able to communicate effectively. And I would caution you to try to use medication with the least chance for adverse effects. Some of these patients cannot express when they're having a problem, and patients could go much further along and sometimes with disastrous effects if you have them on medicines that have a higher rate and you're not able to detect that earlier. The other point is some of these patients really have trouble with lab draws and fight the phlebotomist, et cetera. So I would recommend from a hypertensive standpoint, maybe to choose a drug such as calcium channel blocker that doesn't require as frequent lab monitoring and decrease the burden on the patient, the family, et cetera. Much more to say about those, but I thought those are practical type of hints here. Dr. Alpert is the editor of the American Journal of Medicine. Like Dr. Wright and many other thinkers, they're able to kind of encapsulate major concepts in a brief way and really get a message across. And this, I think, was pretty helpful here. With all these guidelines, between the patient and them, there needs to be a doctor or a nurse practitioner, PA, pharmacist, et cetera, that's using his or her brain. So again, one size does not fit all, and it's important to remember treat patients, not numbers. And I'll end with that. Thank you. I don't hear anybody, so just in case. I think I'm unmuted, but.
Yes, thank you, Jim. If there are any questions for Dr. Lamb about his presentation, we can proceed with those right now. Well, I had a question, and I'll let folks ponder this a little bit. So the SPRINT trial was actually, as several of Dr. Lamb's slides indicate, was intensive blood pressure control versus more routine blood pressure control, trying to bring systolic blood pressure under 120 versus our, the older routine target of 140. And I know that, I certainly believe all the statistics that Dr. Lamb has presented, but it's just so hard to get some of our older folks under 120 systolic. I'm just glad if they take their medication, if their blood pressure is somewhat close to the normal range and they're able to come to their appointments, that would be thrilled. But just wondering, Dr. Lamb or anyone else who's in primary care, how realistic do you think that target is?
Well, it's not easy to do. And we took out some of the slides that looked at earlier trials in older patients and showed when many of them come in with isolated systolic hypertension with blood pressures 170, 180, just saw a 94-year-old with a blood pressure 186. And some of those earlier trials looked at those levels of blood pressure, and by lowering patients down to less than 160, 150, showed improvement in mortality, in cardiac outcomes, and stroke, et cetera. And in some of those patients, that could be a worthy target because you are benefiting them if you can't get them all the way down to where some of the newer guidelines suggest. Remember, the entry blood pressure for SPRINT was in the 140s. And so it's a different level sometimes than some of the patients that you might encounter. However, the number of drugs used was about 3 to get patients down into the 120s. And if using the philosophy of starting low and going slow, in patients who are motivated and want to try to bring their blood pressure down to lower their risk, and keeping in mind the reduction in mild cognitive impairment, which is a major issue for this population, I think these new guidelines have kind of pushed us a little bit further to think about that because of all the things in the older population that carry cardiovascular risk. This is the one that really shows the most benefit. And I'm talking about cholesterol control and all of the other things. And so it could be worth the effort with the patient that's motivated, not increasing the burden of treatment too much, kind of closely monitoring for adverse effects. But I do agree that some of the comments about Sprint and the new guidelines where this is going to place a much greater burden on practitioners because you need to see the patients maybe more often. You need to monitor them a little closer. They may have some side effects that you're going to have to decide whether it's worth it. But that being said, before we started this presentation, we were talking about how this coronavirus thing has driven telehealth and other areas. This might be, if you have a patient that's able to monitor blood pressure at home, maybe a way to do this without kind of increasing burden too much, making adjustments through telehealth and maybe making it not so much a burden to them. The other point, and this kind of comes off of that, is you know, Sprint really measured blood pressure in a very standardized way with an oscillometric device that it may be different than how we measure blood pressure in the office normally. I think this has been covered already in some of the Cardi-OH ECHO programs. So we do need more than just one office blood pressure to make decisions about this. We need home blood pressures. Maybe we should be using the oscillometric device in the office to standardize the methodology and make this closer to what the Sprint model was. And if we don't do that, we may have to, like you said, be careful about trying to push all the way down, because the true blood pressure for the patient may be a little bit different than what we're doing with, you know, the typical patient comes in, they get their blood pressure taken right away. It's the only blood pressure we have. And I think we do have to be careful about using that blood pressure to make decisions to drive people all the way down to a systolic of less than 130.
That's a great point, Jim. And you know, there's quite a bit of evidence that not only does an office blood pressure not reflect habitual blood pressure, but it's less highly correlated with target organ damage and cardiovascular risk than 24-hour ambulatory pressure, for example. So that's a discussion we can get into. Great, thanks for your comments. Just a couple of comments I'm going to read. Well, I think Dr. Lamb already addressed, it's the issue of polypharmacy and side effects. Of course, you have to be cognizant of it, and that's a very good point. Dr. Wright had noticed and made a very important point that the entry systolic blood pressure into Sprint was as high as 180, and they were able to achieve 120 even in the oldest patients, which I think is impressive as well. Dr. Shomo had a question. Anissa, do you?
Yes. I wanted to ask about the kidney issue. So I had a patient, so I'm a geriatrician, so I see a lot of older adults, and I've been trying to aggressively manage their blood pressures. And it's been working well, but the biggest issue I do run into is the kidney issues with some of their creatinines going up. So I had a patient whose creatinine went up from about, I think it was about 1.2 to like 1.7. So I switched her from chlorthalidone, I think, just to amlodipine. But I have a patient now who's that patient was like in her 70s. I have a patient now who's in his 60s, and I've gotten his blood pressure controlled under 130/80, and his creatinine bumped from probably about 1.3 to 1.6. And I repeated it and it came down to 1.5. So I just want to know, like, you know, how much creatinine bump can we tolerate when we're trying to aggressively manage with chlorthalidone, with ACEs, because I believe, I mean, they usually are on amlodipine and everything. They're usually on all the medicines. So just want to try to figure out how much of the kidney bump we should tolerate.
Yeah, I'm open to other answers to this. Like, number one, great job in getting it down to that goal. Two is, for this patient that you just talked about, were they also on an ACE inhibitor or?
Yes.
So
actually he's not, because his potassium kept going down, and I put him on spironolactone, which I usually don't do if they're on an ACE inhibitor. So I believe he's on amlodipine. I would have to look him up, but I believe he's on amlodipine, chlorthalidone, and spironolactone.
Yeah. So remember that with ACEs and ARBs, it's kind of accepted that there could be a 20% increase in creatinine as a normal result of putting them on that drug. So that's the expected result. If it's a 50% or higher, you have to be careful with that. But so sometimes a 10 to 20% bump is acceptable. Secondly, I think there is a phenomenon that as we lower blood pressure, renal perfusion pressure can decrease a bit. So it does sometimes have an effect on the GFR. Thirdly, the kidney portion of the SPRINT study, and nephrologists have stated this, that yes, there was a rise in AKI, but there was still a benefit in patients in terms of cardiovascular outcomes and mortality. And the nephrologists were willing to accept that as a consequence of tighter blood pressure control, because at the end of the day, those patients were alive and they had less cardiovascular demise. So they figured, even though there was that cost of a slight bump in creatinine, they still thought that did not outweigh the benefit from the cardiovascular end. So they were willing to accept that slight bump in creatinine with more aggressive care. You do have to be careful, like I say, again, if you start to double your creatinine and get into that kind of problem, that you might have to make some adjustments in the meds.
So as long as it doesn't double, then you should be okay.
Yeah, again, with ACEs, it's expected that you'll have a 10 to 20% rise in creatinine because of the renal perfusion pressure. So that's acceptable, but still, it requires you to draw blood a little more often and make sure that
right, and that's what is hard, especially now with this coronavirus, trying to get people to come in and get all this blood work. But I just wondered about, because I have some people on ACEs, but I have most people on amlodipine and chlorthalidone, and so it's just like, I've never seen any data though about how much we should let the creatinine go up with chlorthalidone. You know. Yeah.
Again, in SPRINT, they accepted AKI as a consequence of this, but still, again, with the benefits, thought it was not outweighed by that.
Okay, thank you.
All right, thanks to both of you. We have one last question. I'm going to ask Dr. Boland to ask it, and then we'll move on to our case.
Great. Can you hear me?
Yes.
Yes.
Okay, great. Dr. Lamb, that was a great presentation. And I often, I have a lot of elderly patients and I've been treating to a lower target. It's been working fairly well. What I wanted to ask about was the orthostatic hypotension. I had not seen that before in the study you mentioned. I thought that was really interesting. Because I thought SPRINT excluded patients with orthostatic hypotension, and that study, I think the study you mentioned was done in SPRINT. So I guess I'm wondering if you had seen anything else besides the SPRINT trial, and maybe I'm wrong about them excluding orthostatic hypotension, but I thought they did. So it's sort of I'm not totally sure what to make of those results given that simple exclusion criteria.
So Jackson can on to this too, because that study came from him. I think they did have, so the exclusion criteria was a standing blood pressure less than 110, or I think the patient said, "I'm dizzy, doctor," as they're standing next to you when you do it. Those patients weren't included in SPRINT, but they did have, I believe, about a 10% rate of orthostatic hypotension. And again, Jackson may comment on that. And the point they made was that even in that group, intensively lowering their blood pressure did not worsen their cardiovascular outcomes, lead to falls or syncope. What did happen was that no matter whether you were in the intensive or the standard group, if you were orthostatic, you got treated, there was a higher rate of hypotension, sometimes leading to an ED visit, and bradycardia, by the way. But it didn't matter whether you were in, again, the intensive group or the standard group. So there's some people that feel if you can treat blood pressure more aggressively, you actually decrease the rates of orthostatic hypotension by improving baroreceptor function, et cetera, et cetera. So Jackson, you might want to comment.
A couple things. One, patients with uncontrolled blood pressure actually have a higher rate of orthostatic hypotension than do patients whose blood pressure is controlled. That's been shown in multiple studies and in multiple trials. SPRINT did enroll patients and did have a 10%, between 6 and 10% of participants in SPRINT did have significant orthostatic hypotension. to the data that Dr. Lamb presented is correct, that was not associated with an increase in cardiovascular event rate. And the difference, similar difference with aggressive blood pressure control was seen in that patient population. Two is the fact that actually during the trial, more patients developed orthostatic hypotension in the standard arm of the trial than did in the intensive arm of the trial. So that, again, I think that was something that was of concern, was studied fairly closely. There are two papers, one looking at the baseline rates of orthostatic hypotension and the characteristics that were associated with that, and this latest paper that actually looked at outcomes, and both are fairly consistent. Patients with better blood pressure control do better in terms of preventing orthostatic hypotension and in terms of outcomes from either orthostatic hypotension or compared to less intensive blood pressure lowering.
Thank you, Jackson. So we do need to move on. I'm going to ask Dr. Clements to start her case. Jackson had asked, does she have a walker or other assistance?
Yes, she has a walker that she walks with.
And I think Jackson was thinking along the same lines that I was. I think she has some form of autonomic instability. Was she orthostatic when she falls? Do we know anything about that?
I don't know. They have checked orthostatics in the office multiple times, and it has not shown that she was orthostatic.
Okay. All right. So there's a few questions and things that we'd like to address in sequence. I'm going to ask Jim maybe to make a few comments to begin with about exercise for this lady. So in our Fit Me obesity program, we have a disproportionate share of patients who are in this age group who have hypertension, diabetes, just like her, whom we still encourage to exercise. So Jim, do you have some comments to make?
Sure, yeah. It sounds like this lady is actually pretty engaged based on what you've said in your case outline. And she'd like to be more active, but falls are a real barrier to her. And it's not just a psychological fear she has, it's a legitimate concern because of past history. One place to start would be a referral to physical therapy for an evaluation. They can prescribe a home exercise program for her to improve her balance. But, as you mentioned there at the end, there may be some unknown neurological problems that are emerging, or other things that could be affecting balance. But that would be a good place to start, and that could potentially improve her balance and increase her confidence in being able to get some physical activity. In the past, it's doing silver sneakers and pool exercises. That's a group activity, and she seemed to apparently respond really well to that. Unfortunately, right now that's not an option, but in the future, it really would be worth looking at, family and community resources. Her husband, her adult children, are they interested in being active with her friends, neighbors? Does she have senior centers and rec centers that have programs with special rates for seniors? So those are things that might be based on what she's been able to do in the past and what she seems to have enjoyed doing. And that's a really key part of continuing an exercise program, is just simply enjoying it. Those group exercises may be really something to do. And if she can't afford it, to do it something with friends and family or neighbors. With respect to motivational interviewing, one place to start would be, how confident are you that you can get some physical activity without avoiding falling, and find out, just to confirm perhaps what those concerns and barriers that she has. And if she is not able to do very much, and for any reason physical therapy wouldn't be able to be an option for her, there are some very good YouTube videos. There's a series by 2 physical therapists, and they have almost 2 million subscribers. And they have quite a few really good videos on balance exercises for folks who are, for seniors who want to improve balance and get physical activity. And I watched some of those last night. So if she has an internet connection, that could be a really good thing to do. And then there are a lot of videos that actually are workout videos, chair exercises are what a lot of those are. And that can be really helpful. What I recommend for people who aren't getting any physical activity is kind of first beginning a discussion maybe about the inertia that some of us face, you know, about, say, people have exercise equipment in their home. Why is it that that's such a barrier to just starting it when it's just sitting there? And so we have, and just having a conversation a bit about psychological inertia, perhaps to beginning doing physical activity in the home, which can be a real factor for people. And so, you know, what I talk with the patient about is, how about if we set up a plan where it's really easy for you to succeed and really pretty difficult for you to fail? So let's set the bar really low to start with so that you can easily succeed with this program. So instead of shooting for a goal of 30 minutes of physical activity, doing these chair exercises every day, which can feel overwhelming and you know, discouraging to patients, just say, how about if we set a goal of making physical activity a daily habit for you, and the amount of time that you spend will increase naturally over time. So you can do this for as little as 1 minute, and you can check it off on your to-do list that you've done it. But once you start, if you want to continue longer than that, then go ahead and continue longer, towards the ultimate goal of doing it for a longer period of time. So often that can help patients succeed very easily and overcome the barrier of just simply getting started. And I give them a tracking sheet where they can track every day whether they do the activity or not, and just making that little check mark can be a reinforcer for them, and then bringing that in to see you and showing you what they've been able to do and how much they've been able to do it, how many days they've been able to do it out of a month, can be helpful too for some accountability. So those are some of my thoughts.
Thank you, Jim. Even though physical activity will definitely benefit her overall well-being, it might lower her blood pressure to some extent, improve her balance. She does have a BMI of 44. I can just almost picture this lady as quite debilitated, probably looks older than she actually is, and you know, there has a high degree of obesity. And probably has pretty low energy requirements. I mean, when she's sedentary, I remember working with a lady back in Chicago who really would, you know, she lived a few hundred feet from the office, but she would drive there and come in on her walker and sit down and then do the same thing. And really that was her daily routine. Chris, can you comment about how you would even begin with some dietary recommendations and what the goal might be for her as well?
Yeah, so it sounds like there are a lot of things that are happening for her that are positive in terms of not using salt, things like that. Probably the questions are going to be more along the lines of portion size, and also how she's preparing her food. And we've kind of talked about this several times. Just because you prepare it at home doesn't always mean it's healthier. If you're using a lot of dense starch, if you're using a lot of fat in the cooking and things like that. So it'd probably be looking more at, it sounds like she's pretty much a from scratch cooker. And somebody, I would say, of this age probably has a more, I'm going to say maybe farm-like cooking style, with lots of butter, lots of fats mixed in, lots of starches and things like that. So being able to take a broader look at the menu than just kind of a focus on the sodium itself. And that's where you'll probably be able to find where some of those kind of disconnects are between kind of what might be impacting her weight, but also impacting her blood pressure more than just sodium and salt substitutes.
Okay, thank you, Chris. Those are some great suggestions. So I want to give our last few minutes to Jackson. Marilee had some questions about how to optimize her pharmacotherapy. Her systolic blood pressure in particular remains high. I'm actually curious as well. That can be quite frustrating. So Jackson.
Yeah, this is actually a fascinating a 75-year-old woman, 71-year-old woman. As Goutham indicated, she has a BMI of 43.9, a weight of 225, so she's about 5 feet. One thing that also has some edema. One thing you always think about is the obesity hypoventilation syndrome in this woman. Don't know, that may also precipitate some right heart failure. I don't know whether that is the case in her, but she's on carvedilol, 12.5 BID. I'm just wondering whether she has a history of heart failure that prompted that use of that drug as opposed to another beta blocker. Also notice that she's on clopidogrel and aspirin, suggests some history of atherosclerotic disease in the past. Don't know whether that's because of some neurologic deficit that she's incurred, or whether it's for coronary disease. But the patient is at very high cardiovascular risk. There's hyperlipidemia, diabetes, stage 4 CKD, pulse pressure of 90, and a diastolic that's less than 50. So that suggests a very high risk patient patient. The fact that that low diastolic blood pressure raises the issue of the J curve in her, but will, as indicated in Dr. Lamb's presentation, a low diastolic blood pressure does not mean those patients, if you achieve a systolic blood pressure control, that does not increase risk. If anything, it decreases risk, even in patients with a low diastolic blood pressure. The issue of the rise in creatinine in patients who have well, this patient has CKD. So she needs a diuretic. 20 of, probably even 40 of Lasix in this woman is insufficient for adequate blood pressure control. So she needs additional diuretic, and probably would use it twice a day. A diuretic dose of twice a day. She'll probably end up on something like 40 twice a day in order to achieve appropriate blood pressure control. The rise in creatinine, particularly in patients, when you lower blood pressure and when in patients who are also on a RAS inhibitor, you can expect the creatinine and the EGFR to go up to about 30% higher. And in fact, those are the patients that actually do better in terms of long-term renal function compared to those who have very little response to those drugs. So that the spironolactone is good. The fact that she may have obesity, hypotension syndrome, and therefore is at high risk of sleep apnea, that makes spironolactone a particularly good drug to use for blood pressure lowering. However, the caveat is in this patient with diabetes, stage 4 CKD, that also puts her at much higher risk for hyperkalemia. And so it was good that probably that would not be my first choice in terms of additional antihypertensive therapy. The 20 milligrams of Lasix, 40 milligrams is probably going to be too low for effective blood pressure control. Overall, I would say, yeah, it would be you would still try to achieve a systolic blood pressure the target would still be less than 130 in this lady, particularly in this lady at very high risk. Should be able to achieve it with additional increase in diuretic by increasing her Lasix. You also still have room to increase her beta blocker. She's only on 12.5 of carvedilol. If she's on it for heart failure, then you have to leave her on that, or go to another beta blocker longer acting beta blocker, and you still have room to titrate that up. She's already on the amlodipine, and that is fine. One other point I will make, and that is when you see patients on RAS inhibitor, and diuretics and lower blood pressure, the GFR goes down. Amlodipine will increase the GFR, but that increase in GFR is hemodynamic, same as the worsening renal function by at least GFR with lowering blood pressure and the use of RAS inhibitors. But the protective effect of the slight reduction in eGFR, the increase in GFR with the dihydropyridine calcium channel blockers, in fact, has been associated with a worse outcome unless the patient is on a RAS inhibitor. I had to say that fast. I know it raised a lot of points, but because we're out of time. So I hope those points were helpful, but bottom line is you still have room to reduce her blood pressure by increasing her diuretic and potentially increasing her beta blocker.
Thank you, Jackson. So the bottom line really is go up on her Lasix, I think. And then we're going to turn it back to Shannon for a moment.
Thanks, everyone. I just wanted to remind you that we're nearing the end of our series, and you'll receive 2 surveys from us at the end. You'll get your post-clinic survey and your exit survey. And I'll remind you of these dates as well. But you will also, if you wish to claim CME credits, receive a survey through myevaluations.com. You'll have to register with myevaluations.com to start the process. Next slide. You can always watch previous ECHO clinics on our website. And finally, please answer the survey that you have received this morning by 5 p.m. tomorrow. So thank you so much. We'll see you next week. Everyone, thanks. Stay well, please. Bye.
Thanks, everyone. Bye-bye.